because that will take some time, but do feel free to introduce yourself when you speak. Item 2 is notice of recording. So this meeting will be being webcast. Are we lined up to start the webcast, Errol?
Baljinder, we're ready to start the meeting now.
You've started. Okay, great. So the meeting will be webcast, and any of the participants are entitled to record parts or all of the meeting, and indeed take photographs if you wish to do so. A couple of items of housekeeping. As usual, if you wish to speak, please do raise your electronic hand, and I'll keep an eye out for that and bring you in. And whilst you are not speaking, please, if you could turn off your microphone, so that helps with the sound quality. By all means, you can switch on both your microphone and video when you make a contribution. Item 3 is apologies, and I have apologies from Dr. Mania Aslim, Dr. Parmjit Marok, and Richard Burden. Are there any others? No. We'll note those 3 apologies then. Declarations of interest. Anybody wish to declare an interest in respect of any of the items on today's agenda? Again, not seeing any hands on that. So we'll move on to the minutes. The minutes of our meeting on the 21st of July have been circulated. Is everybody content that they are accurate?
Great.
Thank you. Which takes us on then to item 6, which is the COVID-19 situation update. Justin.
Great. Thank you, Leader. And I will just get the slides up to share with you. 1 second. Here we go. So I won't go through these in detail, but I will try and pull out the key points for the board. And as you know, we publish these on a monthly basis. So what we're seeing at the moment is that the case rate is flattening out to some extent. And it's still early days to say whether that's because testing slowed down or because this is the impact of vaccination. My sense is that it is the impact of vaccination, in that we are not seeing the same scale of household clusters that we were in the previous waves. So when COVID is in a house where the other residents are vaccinated, they are not necessarily catching it. We know that vaccine is not perfect at stopping you catching COVID, but it is pretty good. And I think that is partially why we're seeing that the case rate's starting to come under control. There is still significant pressure on the NHS. And we are still seeing high pressures, which I will come to later in the presentation. The death rate and the death numbers are starting to slow down. But what we're seeing now in deaths is what happened in the community almost 2 months ago because of the time lag in terms of the deaths. So they are higher than perhaps this slide suggests. And we will see in a later slide the kind of pattern of the deaths that's happening. So overall, our case rate is falling. Our testing rate staying pretty stable, which is a good sign, and our percentage of positive tests is starting to fall. And that's really the indicator that will give us the strongest sense of whether the pandemic is starting to decline again and we're going into a valley in terms of the case rates. So that percentage of positive tests is the thing to really focus on. Overall, we're following a similar pattern to the rest of the West Midlands. Wolverhampton, as you can see, has had a little spike up linked to a particular local outbreak, but overall, we're seeing the case rates in all ages following a similar trend across the West Midlands. In terms of the pattern of cases, as you can see, there are some largish numbers now in individual wards, but actually when you look at that as a case rate, it's relatively stable, and there aren't numbers here that make me particularly concerned when you look at the overall population in each ward. And as you can see, when we look at the ward data as a case rate, some of those wards that are in the previous slide were dark because the absolute case numbers do not appear in the top 10 case rates by wards, and that's because across Birmingham there's quite a lot of variation in the total population size in each ward. And you can see also that some of the areas which historically through the pandemic have had very, very high case rates, wards like Lozells or Newtown, are not in the top 10 currently. And that's really good news considering how far we have to go still in vaccination in some of those areas. So that's positive news. Overall, the wastewater data is showing a similar pattern in terms of relatively small amounts of change across the city and wider region. When we look at variants of concern, as you know, the Delta variant is now dominant both in Birmingham and across the UK, and increasingly gaining dominance across the world. The variant of concern that we are watching with care at the moment is the one that comes primarily from South America, which is called Lambda. It is much more infectious than previous variants. And we have no cases in the West Midlands currently, which are of this variant. But there are a small number of cases in the UK, all linked to international travel. But we are watching that situation closely because obviously that presents yet further threat from COVID to the relative stability we're now starting to achieve. In terms of testing, the majority of testing is now through what are called the home channels, people ordering kits directly from government to be sent to their homes. We have maintained in Birmingham a network of 104 pharmacies where people who feel nervous doing a lateral flow test at home can go in and do it at a pharmacy. And we also continue to maintain the collection sites around the city, as well as various pop-ups. We had a very successful pop-up at the weekend at Frankly Services, which gave kits to people both travelling into Birmingham, but also people from Birmingham travelling out. And the feedback from the public was incredibly positive that actually people are consciously taking a lateral flow test before they're going to visit relatives or friends, before they're travelling or before they're going to large events. So that's really positive, I think, feedback on how this is going. We look at PCR uptake. There is some patchiness across the city in terms of uptake, and that's often where we're using PCR in the context of localized outbreaks or situations. And when we look at lateral flow testing, again, the centre of the city has been consistently had a lower testing rate than the rest of the city, but this is pretty good compared to where we have previously. And in the next slide, you compare the 1st of August to the 29th of August. Although the ranges are slightly different in that the upper limit at the 1st of August was much higher, what we see in the 29th of August map is a much stronger coverage across the city. So the majority of the city now achieving a much higher rate of testing than previously, which is exactly what we want to see. There has been some fluctuation in testing rates, and we've seen particularly the testing rate in 17 to 18-year-olds start to spike up as students move back to university and return to sixth form colleges. And that's good. I think that's a strong reflection of the positive attitude towards parents and young people towards acting responsibly for the return of term. No significant differences for previous patterns in terms of ethnicity, and in general, most ethnic groups are sitting in the same kind of band of testing, which is good. And similarly, when we look at deprivation, there isn't a significant variation. When we look at case demographics at the moment, again, consistent pattern in terms of the age groups, nothing particularly concerning there. And we are starting to see the case rates in the young adult population starting to fall. We will be watching this age group closely as the universities return to campus, but also the school age population, where we anticipate we will see a rise as children start to mix more at school and in out of school settings. Slightly concerning that we've seen an increase in case rates in the over 60s. However, some of these populations are quite small, particularly the over 80s age group, where we have had an increase in cases. However, in absolute numbers, that is a small number of increases. And what we are clearly seeing in care homes is that unvaccinated staff are bringing COVID into the care home. A small number of residents who have been vaccinated are catching COVID, but they're not becoming unwell and they're not having to go into hospital, which is really, really good news. That's what the vaccine does. It stops you going to hospital, it stops you dying. So some really positive evidence that the vaccine works in terms of preventing severe illness and death, particularly in the elderly. And that, I think, is comfort to us when we look at these this increase in rate. Again, pattern for ethnicity hasn't changed significantly, and no particular concerns to raise, either when we look at case rates or when we look at the overall pattern. It is heartening to see the case rates starting to fall in our African and Caribbean communities, particularly given those communities still have some of the lower levels of vaccine uptake. And there's no significant pattern to highlight in terms of deprivation. In terms of the NHS situation, as I said, it remains significant pressure on the NHS and a high number of patients in hospital and in intensive care with COVID. And this we would expect to be the pattern for the next couple of weeks until the impact on the NHS starts to take a downwards trend, as it is in the community at the moment. There's normally a 3 to 4 week time lag between the pattern in the NHS and the pattern in the community. So this is exactly what we would expect to see, but it is a really important message for those watching to hear. The NHS is still under immense pressure because of COVID. And people are working incredibly hard to ensure that people who need healthcare get it. But there is still a huge amount of pressure on the system because of COVID in our hospitals. And when you look at this across the wider health economy in Birmingham, Solihull, and in the Black Country in West Birmingham, as you can see, the number of patients admitted is staying pretty stable. There's no great drop off. And it's been pretty consistent for the whole of July and August in terms of those high levels of pressure on the NHS in terms of hospital admissions. And it's important to remind the board that hospital admissions are the tip of the iceberg. Whatever we see coming into the door of a hospital is probably multiplied by a factor of 10 in terms of the pressure in primary care and general practice. So whatever we see here will be playing out in primary care at a significantly higher level in terms of pressure on GPs and on pharmacists. As I said, in terms of deaths, we're now at the point where the initial rise in cases is translating into deaths, and we're seeing slightly higher numbers, so 19 deaths reported within 28 days of a positive test, and 14 deaths in which it was on the death certificate. But overall, the death numbers are below what we would expect for the 5-year average at the moment, which is good news. And that means that the pressure on the mortuary on the death certification process is manageable. In terms of situations, we have seen an increase in what are called exposures. So those are situations where we have just one case identified, and we've had a significant increase of exposures and outbreaks associated with workplaces and public venues. And you can see the clustering on the map of those little triangles, which are predominantly around the city centre, which really reflect that as more people have been out socialising, attending entertainment venues, going to work, that we are seeing cases appearing, and that those are leading to investigations and support for those settings in terms of COVID safety. And overall, it has been the increase in workplaces and public venues that has driven the increased pressure on the public health response team. In terms of contact tracing, we've restarted what's called Local O, which is our direct contact tracing of positive cases faster, receiving them faster from the national system. It has a more positive impact and I think a better response rate than the national CTAS system. However, we are finding that there still remains a bit of confusion for people around the isolation guidance. And it's important to reiterate that if you live with someone or are in close contact with someone who tests positive, you have to isolate for 10 days unless you are under 18 or you are 14 days after your second vaccination dose. So it's one or the other, you're under 18 or 14 days after the second dose. If neither of those apply, you still have to isolate, and that is still legally enforceable, and there is still a fine if you're found not to be isolating when you should. And we continue to do some spot visits and spot telephone calls of people that should be isolating to check whether they are abiding by the guidelines. In terms of comms and engagement, I won't go through this in detail, but within the pack, you've got quite a good detailed update of what we're doing, supporting both the vaccination programme and the ongoing awareness of comms and engagement. I particularly want to highlight the session that we did on the 19th of August with young people who are supported by the St Basil's charity. It was an amazing session facilitated by two of the young people who were incredibly professional, managing the questions and the answers, and I really do want to just highlight them because I think it was a brilliant opportunity to talk directly to young people, answer their questions and their concerns about vaccination and about wider COVID issues. And we've included in the side pack as well more detailed updates, both on the champions, our work with the faith community, some of the work that we're doing specifically around vaccine awareness and understanding, working jointly with the NHS, both going out and doing kind of question and answer pop-ups and surveys with local citizens to understand concerns, but also doing direct door-to-door engagement in wards where there's the lowest uptake of vaccine and asking people, have you had the vaccine? And if not, why? What's the reason? Help us understand. And where people have said, well, actually, I would be interested, but I don't know where to get it, those doorstep teams are helping people get to the nearest vaccination site for them. So I think that's a really positive thing to share with the board. We've also included details of some of the work of our partners, and attached to the report as well in the second slide set is a detailed summary of the work that our engagement partners have done over the last year, which has been a pilot of, or a different way of working for the council, commissioning partners to deepen our engagement with specific targeted communities. And there are over 30 targeted communities which these 18 partners have been working with. And as I said, in the second slide deck that's available on CMIS, there's much more detail about the work that those partners have been doing over the last year. So I'm happy to take any questions for the board, and I hope that was a useful overview.
Thank you very much, Justin. Some positive things there around both communication and engagement with other partners. Let's take some questions then. Councillor Paul Tilsley.
Thank you, Leader. Justin, it's a question that I should have asked probably, but have deliberately not asked in the last couple of sessions. In all the statistics that you've produced over the last 2 months, the comment has been that 75% of hospital admissions have either had no inoculations or have had one. By a simple deduction, therefore, 25% have had their double dosed. Is that a correct assumption?
So, Councillor, if I can ask you to wait for the next item, my colleague, Dr. McRae, Duke McRae, will be giving a presentation on the hospital admissions, and part of that is actually the exploration of the vaccination status of those admitted. So I think if she can pick that up in the response when she's presenting the next item, if that's okay, because it goes into it in some detail.
Thank you.
And I think, Paul, it's actually quite interesting if you have a look through the slides for item 7, which Julie is going to take us through on the next item. Bridget?
Thank you, and really helpful presentation. Thank you, Justin. Just on the vaccination, so I've heard anecdotally concerns about people being turned away for vaccinations because they didn't have proper ID on them. And nowhere on our website does it say that you need ID to get a vaccination. Could we just clear up what the situation is on that, please?
Yeah, so at most of the sites, but particularly the mass vaccination sites, so Millennium Point, Aston Villa, they will help with what ID you need. You normally need a piece of ID, and the information which we signpost people to on the NHS website, which is signpost to from the council website, does say you should take some form of ID, but it doesn't need to be a passport. It can be a bill. It's just anything with your postcode on it. But if you don't have it, then the people on site at the walk up site will help you find out how to register. The reason the ID is important, it's not about checking who you are. It's actually about trying to link you to your NHS record, because what's really important is that your vaccine, when it's given, is recorded on the NHS system and connects back to your GP, so that when you need the vaccine passport, for example, to go abroad or to travel, that data is linked. Because if it isn't linked to your NHS record, you've got no evidence other than the little card that you've ever had the vaccine. And I have to say the NHS teams have got quite good at this. We did a pop-up probably about a month ago with the Chinese Community Centre in partnership. And we had quite a large number of what are called undocumented citizens attend who had no ID. And the NHS team were absolutely able to help them. It may be slightly different if it's a GP practice or a pharmacy site, but certainly at the walk-up sites, I know that they're perfectly capable of helping people to navigate if they've forgotten their ID or they don't have it with them.
Thanks, Justin. Okay, I'm not seeing any further hands, so if we could note Justin's presentation, and we'll move on to item 7, which is the COVID-19 hospital admission and vaccination position. As I've already indicated, there's some quite interesting information in the slide deck for this. So I'll pass over to Dr. Julia Duke McRae. Julia.
Good afternoon, all. Hello, can you hear me?
Yes, we can. Yeah.
I'll just share my slide.
Great.
Can you see the slide?
Yes, we can.
Okay. So I'll start off with the first one. Okay. Hello, everyone. The purpose of this report is to present to the board for information the demography and vaccination status, as Justin pointed to earlier on. And the work was done around between May and August this year. And the study was just to look at the distribution of admissions by ethnicity and age, but also to assess the impact of vaccine on the overall hospital admissions and types of admissions. So the actual report itself, there were a total of about 530 patients admitted between the months of May and August. And of that, 67 patients were admitted to ITU and the rest in the non-critical care. So the data suggested that in terms of the breakdown of the age group, overall, most of the patients who were admitted were below 64 and below, and the highest number of admissions was within the 35 to 44-year age group. And in terms of ethnicity, the majority of those admitted were in the white and Pakistani ethnic group, and also where the ethnicity was stated. And also, in terms of the numbers from those group, those who were then vaccinated, we considered those who had been vaccinated having had 2 doses and disregarded those who just had 1 dose. So looking at those 2 groups, 47, about 48% of the white ethnic group had had 2 doses of the vaccines, and 26% among the Pakistani ethnic group. Now, what is important in the findings is about 38% of those who had received 2 doses of the vaccination, we didn't know what their ethnic grouping was. Now, in terms of the status of those who had been vaccinated, quite a large proportion, so about over half, had not been vaccinated who had been admitted in the hospital completely for COVID vaccine. Sorry, for COVID infection. 37% had had 2 doses of the vaccine. 54 had not. Now, when looking at the critical care admissions, there were 67 patients who had been admitted in ITU. Now, of those admitted in the ITU, most of them fell within the 64 and below age group. So we didn't see a high number of older patients. And in terms of the ethnicity distribution, 34% were the white ethnic group, 19% the Pakistani, and 23% were those who didn't have their ethnicity stated. And looking at the vaccination status of those who had been admitted in ITU, a high proportion of those had not been vaccinated. So 66% had not been vaccinated, and 27 had had 2 doses of their vaccine. Now, in assessing the impact of vaccines vaccines on the overall hospital admissions, we looked at both the those who had been admitted right both in ITU and non-ITU patients. There was a statistically significant difference between the two groups. And basically what that means is that you are more likely to be admitted in hospital if you had not had your vaccines, if you had not had 2 doses of the vaccine. And similarly, also in the ITU unit, it was the same thing I found. You are less likely to be admitted in ITU if you had 2 doses of the vaccine. If we now look at the intervals between the second dose of vaccine and admissions, the study found that the data suggests that most of the infection occurred within 4 months of receiving the second dose of the vaccine. So looking at overall, the summary, what the data suggests is that hospital admissions are predominantly in the younger population. Majority of the admissions were in the white ethnic group and the Pakistani ethnic group, where ethnicity was, and in a group where the ethnicity was not stated. So what this would mean for us going forward is the need to make sure that the data on ethnicity is completed for us to have a good picture of what's going on in the hospital. There was also a significant difference in the overall hospital admissions between those who had 2 doses of their vaccines and those who had not. And there were fewer admissions in those who had completed their doses of vaccine, both in the overall hospital admissions and ITU as well. Now, in terms of patients who had completed 2 doses of the vaccine, most infections occurred within 4 months of the second dose of vaccine. However, the reasons for this are still not yet clear. So going forward, the recommendation is that we continue monitoring COVID-19 hospital admissions and vaccination status. And this is to determine the efficacy of the vaccine with time. Thank you.
Thanks very much, Julia. What interested me about this presentation, well, I say interested, it surprised me really that the numbers of those with 2 doses, both admitted to hospital and ending up in ITU, were, I thought, quite high at 37% and 27%. I just wonder, is anything known about the people who ended up in hospital and had 2 doses? Were the majority of them perfectly healthy individuals, or were there individuals who had some other underlying condition that meant that the vaccine, in spite of having 2 doses of the vaccine, they still ended up in hospital or in some cases on ITU?
Unfortunately, I mean, that's a very interesting comments, Councillor. Unfortunately, the data we have access to does not provide that information for us to dig deeply into the data to do the analysis to understand that. But hopefully we could work with our colleagues in the NHS to do that piece of work to understand that. But the data we were given didn't have that information.
Okay. As I say, I was surprised that just over a third of people with 2 doses have ended up in hospital. Maybe Justin, you could shed some light on that.
Thanks, Leader. I just want to check with Julia on this data set, because I know in the ITU data set, it is patients which are in ITU with COVID, but the hospital admissions I thought was patients who have COVID, but it may not be the reason they were admitted. No,
they were all patients who were admitted
with COVID as their primary.
With COVID as the primary, so
yes. That's really important thing. Yeah. The other bit that, so we know the vaccine's not 100%. We know that if you have 2 doses, you're much less likely to end up in hospital, much less likely to end up severely ill. And this data reinforces that, but it also reinforces it's not perfect, which is why we need hands, face, space. People need to keep washing their hands, keep sensible about wearing face coverings on public transport. The other thing that's not possible in the data that Julia currently has access to is to report on the length of stay. So anecdotally, what we've been told by the hospital is the patients that go into hospital but don't end up in intensive care with 2 doses of the vaccine go home much faster. So basically, I suppose what it's kind of describing is people still can get sick with COVID, but they actually get better much, much faster if they've had 2 vaccines and they go home quicker, whereas the unvaccinated tend to stay in hospital and get sicker and sicker and sicker. So the vaccine is still doing what it says on the tin, which is stopping you getting severely unwell and stopping you dying, but it's not perfect. And we know that, 25 to 30% ending up in hospital is still significantly better than the flu jab, which is only about 50% effective. So we're still kind of quids in. But I think there is the ask, and I think Paul's on the call with us this evening. There is the ask to Paul, if you're able to help us get more access to the data from the acutes, because this was the data I think that came from Sandwell and West Birmingham and from UHBT. And I think it is important to get the kind of granular stuff around length of stay as well, because it reinforces that the double vaccinated are far less sick than the unvaccinated. And that's what all the clinicians are telling us.
But I'm very happy to talk to them about that. I think the other kind of headline figure that's quite powerful is that the average age of people in ITU in this wave is about 10 years younger than the average age of people in the last wave. So if you turn the question around the other way, if we know the best part of 3/4 of the population is vaccinated, we know that older people are much more likely to be severely impacted by the disease, but the average age of people in ITU is coming down. That also reinforces how powerfully effective the vaccine is. And whilst we don't know the individual details, my kind of anecdotal conversations with folks at the QE suggest that many of those who are in ITU with COVID have a lot of other things going on as well if they're doubly vaccinated. They're not just there with COVID, they've got all sorts of other conditions that have got them into hospital. So, but I'm happy to talk to UHB about whether we can find a structured way for them to give you that data without it being too much of a burden.
It would be useful, Paul, to have that, because it would be more reassuring, I think, if people who've been double dosed with the vaccine and ended up in ITU, if that was because they had other underlying health issues, that would be a little more reassuring than the stats that have been in this slide deck. Because as I say, it did surprise me. I understood that the vaccine wasn't perfect, couldn't absolutely prevent you from getting it, but I thought it was a little bit more effective in preventing you ending up in hospital or on ITU.
Well, the other thing, Leader, is if you compare the numbers of people in hospital in this wave to the numbers of people in hospital in the last wave against the case rate, you'll also see that's a very clear indicator. Whilst we've still got 200 people in the 3 UHB hospitals with COVID, at the levels of case rate that we had a few weeks ago, we would have been back where we were earlier this year when we had in excess of 1,000 people in hospital. So that's another really powerful indicator. I mean, Justin's right, nothing's perfect. It doesn't work for everybody, but it's a really, really powerful indicator. We have nothing like the numbers in hospital that we had in the first wave.
That's very good.
But I also think, but I also want to point out that in this particular study, we're seeing much fewer older people who are being admitted compared to what it was previously. So it's actually working well for that group, which is who we were targeting initially. But also important to note that there may be, but I think for the investigations need, there may be a waning of the vaccine and hence the promotion of having a booster dose as well.
Yeah. Okay. Paul, thank you for your patience.
Thank you, Ian. Forgive me. I didn't get that far in the pack. I only extricated myself from the loving care of the QE on Sunday afternoon. That's another story. What is interesting on page 109, if you look at the data, the interval between the second doses and admissions, after 2-3 months, it's 44. 3 to 4 months, it's double that at 87. And then 4 to 5 months, it's a third of that. And I think the point that you originally made was, are there any underlying conditions? And was there an issue surrounding the prevalence of whichever vaccination was being used at that particular time, if you trace it back.
Justin.
Yes, I mean, I think there's a good point there, Councillor Tilsley, and I'm sure Julia will be able to have a look at this and report back for the next board, because if we look at three to 4 months after their second dose, and this is covering, I forget what the time period is, but I think it's everything between May and August. So 3 to 4 months after your second dose, if you were admitted in August, your second dose will have been May. Now,
Yep.
at May, the majority of people under the age of 60 who had their second dose were the clinically extremely vulnerable. So there were people with existing significant health conditions. And we do know that the vaccine in people who've got immunosuppression or who are very elderly does start to wane. That's why we're looking at the booster to pump up their immune response. So that may well be behind it, because actually looking at the date slot of May to August, the only people that under the age of 60 really who will have had 2 doses are healthcare professionals, health and social care professionals, or clinically extremely vulnerable. So there may well be other complicating factors that are meaning they're much more vulnerable and the vaccine won't be quite as good, which is why national government are considering roll out the booster alongside the flu jab. And we should have details of that for the next board. But I think that time window and when we know they will have had the second dose gives us a steer to where people are much more likely to have other conditions.
Thanks,
Okay.
Justin. Thank you.
Yeah, thanks, Justin. It will be interesting as time moves on, and there's a bit more work done in this area to see what emerges around these. We'll move on to the vaccination rollout and uptake, and Paul Jennings.
Yes, they do. It says Paul Sheriff on the agenda. They've been slightly premature about my demise. Paul Sheriff's taking over from me in terms of attending this meeting in future. I'm going to attempt to share something very quickly, but I'm pretty useless at this stuff. So let's see if this works. Has that by any chance arrived?
No, sorry, it hasn't.
Okay, right. So I'm not going to. No, hang on. Sorry. Right. No, I'm not going to waste time, Leader, showing my incompetence. I'll just talk to you if I may very quickly. In terms of uptake across Birmingham, we've administered just under 650,000 first doses and just over 550,000 second doses. There's still quite a range of rates of vaccination. You'll know that we have a very young population, and therefore our vaccination rates in the younger age groups are still lower than they were in the higher age groups. And that's simply because of the shape of our population and the fact that we're only really able to begin vaccinating younger people towards the end of the vaccination programme. We're making good progress, actually, because the figures that I was sent to give to you today suggests that we've only had a vaccination rate of about 17% with the youngest, the 16 to 17-year-olds, and I know we're already well ahead of that. What I think colleagues on this call will have heard, and Justin's referenced it already, the two things. One is the likelihood of a booster vaccination programme, and we're still waiting for the details of that to be announced. We anticipate it will be a booster vaccination programme for the over 80s, for those who are immunocompromised and for those who live in care homes, along with health and social care staff. We think that's probably about as far as the campaign will go, but that's based obviously on those who are most vulnerable, who are least likely to be able to generate antibodies on the back of the vaccination programme, and those who are most in the the front line in terms of being exposed through health and care situations. We're in the process of continuing to encourage those who work in care home situations to be vaccinated. We announced the likelihood of an immunisation programme for COVID in schools. We anticipate that we should be hearing the announcement in respect of that formally at the end of this week, and we have been planning our approach, which we hope would enable us to deliver to all those who are willing to receive it a first COVID vaccination between now and half term of all the 12 to 15-year-olds in Birmingham. The planning of that will be detailed publicly once the announcement has been made public, rather than being sort of leaked through the press and so on. But all of the plans for that are currently in place, Leader.
Thanks very much, Paul. And the booster situation is obviously continuously under review as more and more data emerges.
Yes, I mean, I think as Justin said, it's clear that there are those for whom the first 2 doses are not as effective or as long lasting as they are for others, and I think that's where it's like to be focused. So earlier on in the year, you would have heard people boosters for all those over 50. We're now very much focusing on a conversation about those over 80. What we're also hoping to be able to do, but again, we're still waiting for the final nod on this, is to be able to administer a COVID booster and a flu vaccination at the same visit. Not in the same needle, I'm afraid. It's two pricks of a needle, but at the same time, which obviously will be much more efficient in terms of delivery and logistics.
Yeah, the reason I asked that question is because, as I understand it, in Israel they are rolling out boosters to all over 50s.
Yes, they are, Leader. But I think Israel were the first to begin a vaccination program, and I think they've vaccinated the highest population, but they had at least at one point vaccinated the highest percentage of their population of any nation. So they're taking a different approach. Our approach is led by the Joint Committee on Vaccination and Immunisation, and we're following their guidance, which is generally very carefully thought through.
Okay, Paulette.
Hello, Paul. You're right. Right, my questions are quite quick ones. The first one, this business about the vaccination in the care homes and the fact that staff in care homes will be redeployed or be asked to leave their jobs as of the 11th of November. My concern with this is it's not been promoted very well. Paul, what has been put in place to really ramp up the communications and the promotions so that people are absolutely clear that the government mean business on this particular point? And my second question is around the 12 to 16-year-olds. Is that going to come to pass? I'm a bit behind with my reading at the moment, but the 12 to 16-year-olds, surely to God, if they're going to bring in vaccinations for that age group, they would be talking about doing it now, just before they go back to school, or at least when they go back to school in that first week. But it's still under discussion. Is it likely to happen or not?
So let me take those questions in reverse order for me. My understanding is that we're likely to hear the final ruling of the Joint Committee on Vaccination and Immunisation on Friday of this week. We have plans in place to begin next week. We can't begin on Monday if it's announced on Friday. We'll have to have a conversation with the schools first, but schools are alerted to it and are, well, I'm sure we'll cooperate with the programme. The population of 12 to 15-year-olds in Birmingham is approaching 75,000, I understand. So practically, we cannot do them in the first week. We'll aim to do them in the first half of the half term. That's as fast as we can get through it. In terms of the communications and conversations with care homes, we have worked really hard, and we particularly includes the council. The adult social care team have been in constant dialogue and contact with the care homes. I know they had a programme in place over this last week where there's been a conversation with every single care setting in Birmingham. Get another one. It's another conversation to bring them up to speed, to help them to understand, to encourage them to supply us with the data so that we can keep on focusing our needs. We've been talking about taking our mobile vaccination units out. We've got, GPs having conversations, because all the GPs now have a relationship with the care homes, because every care home has a GP allocated to them as part of a scheme that we have in place. So I can honestly say there can be nobody really who doesn't now understand that this is not a drill. This is serious.
The reason I'm asking that, as long as the leader doesn't mind me coming back, is because I absolutely support what you're saying. You're spot on. But my issue is the wider public. At the moment, I know that the care homes, the work is going on, but unless I've missed it, the way they've done it with the university students, where they've absolutely promoted it out there, as of September, they can't go into any clubs or anything. It's been a bit more subdued with people in the care homes. And I believe it's the start point for the government rolling this out to other bits of both the health service and out there in different parts of the community. But they've not been as vocal with their communication so that the public knows that this is happening, if that makes sense to you.
I'd agree with you there, Paulette. There's not been very much in the way of communication of this law change at all. Paul?
We excuse me, sorry. We're in the process of trying to understand the implications in terms of those who go into care homes. So that there are lots of folks who are required to go into care homes or need to go for their jobs, who will not be able to go in future unless they've been doubly vaccinated. So we're going through an exercise over these next 2 weeks to scope who those organisations are and what level of population they have that's unvaccinated, so we can start a structured conversation with them. Councillor Hamilton's absolutely right. This would have been much easier and much clearer if the step within the NHS had been in time with the step in social care. So there was a consultation in progress in the NHS, or about to be consultation in progress in the NHS, and I wouldn't be surprised if it comes to the same conclusion. But doing it in 2 steps actually makes it really quite complicated for people to understand. It'll be the responsibility of the manager of the care home to check that those coming in have been appropriately vaccinated, and again, that could be quite a difficult task for those individuals. But honestly, I have to say, Councillor Hamilton, that your colleagues in social care are working tirelessly on this, and we've, in our programme board for the vaccine programme, this has been the main thing we've been talking about for the last month or so now. It's very much at the focus of our attention.
Thanks, Paul. Okay, I'm not seeing any further hands, so if we note Paul's update. Item 9 is the enforcement update, and if I could just draw your attention to para 3.1 of this report, which states that following the last update to the board, nearly all the emergency coronavirus legislation has been revoked. As a result, both West Midlands Police and Birmingham's environmental health team have little in the way of powers that can be enforced to control the spread of coronavirus. There is therefore no actions to report to the board. Therefore, this report is tabled for information. If anybody does have any questions on it, can I suggest that you email Mark Croxford at Birmingham City Council, and he will be able to give you a response. If we can just note that report then, given that it is tabled simply for information, and we'll move on to item 10, which is living with COVID, a strategy. And Justin, you're going to talk to this?
Actually, I think Hedi's been able to join us.
Okie doke. My apologies.
Good afternoon. If I may, from the discussions we've been having, as you can see, especially on the presentation by Julia, she mentioned, and the fact, the nature of the questions and the nature of the context of the COVID has evolved and is continuing to evolve. So this paper is mainly presented to, it will be a paper presentation to articulate and mention the fact that we are moving through a phase from the emergency response to a different phase, and the strategy will be geared towards addressing those new challenges. So, for example, from that discussion, we noticed the nature of the questions. We're going to be drilling down more to learn more about what's happening, and we need a slightly different strategy from the first phase when we were more on the emergency process. And you also, the council also needs to know, the board to note the fact that the emergency response has been stood down to the pandemic in August 2021. So effectively, some of those processes, as you just also mentioned about the environmental enforcement and other things, are changing. And that's, again, part of the rationale for trying to have a slightly different push on how we respond and deal with the pandemic. Also, it's important to note that given we ramped up both capacity and others, but now in a different phase, we also need to have a different strategy in terms of moving towards business as usual, as well as how we approach the general dynamics. So those are essentially part of the rationale for trying to have a slightly different strategy to deal with the COVID response. But for Birmingham in particular, as noted, given both the Commonwealth Games that is coming up and the challenges that will come with that, and also the winter pressures, which introduces other infection diseases like norovirus and respiratory syncytia, we're going to try to change, again, the approach to tackling with COVID. So this is really pointing out the fact that there is a change phase and subsequently a change strategy would follow up to be able to deal with that. The details of the strategy, what we've done is just outlined the steps, but essentially it's still the same broad. But now more the data and surveillance will go more into details in order to learn lessons to strengthen the resilience capacities that have through the first phase, identify those capacities and find the best way to strengthen them so that in the event that the changes, we now need to be able to build on those capacities in order to be able to manage it better, and especially to learn lessons. There's some work I understand that's presently going on in the council about learning lessons from the COVID. So we will pick some of those broader lessons, but also try to drill down more into the public health response. And all those information, hopefully, would enrich the strategy that we'll be presenting in more details at the October meeting. So the key things we'll be doing is there will be a strategic review of what has happened during this emergency phase, and then we'll draw lessons from there. In the process, we'll be discussing with both members of the board, either in terms of in-depth interviews with key individuals, or also mini focus group discussion to be able to pull out things. So apart from the analysis that will happen in terms of the data, the soft issues, the relationships, the dynamics, and because it's an adaptive process, we need to be able to capture what really made it possible for us to be able to respond the way we've responded in order to build on that. So those final bits are the things we will try to be able to pick up. And as we've also noticed, in terms of the effectiveness of the vaccines and the implication it might have, both in communicating the impact of that and in being able to be prepared to respond if things were to change. We also need to be able to have that capacity. So all this means that the strategy we are going to come up in order to be able to live with COVID as one of the, for want of a better word, diseases that we need to, the same way we're living with HIV/AIDS, the same way we're living with flu. The specifics might vary, but we'll try to have a strategy that we'll be able to communicate those points. So that's really what I can say at this stage about the plan to develop the strategy. But hopefully by the next board meeting, we'll then be able to give you a more detailed strategy that has the specifics of what we are thinking and incorporates the lessons that have been learned and how we can use those lessons to be able to move forward. So that's really why I thought I should present. Thank you.
Thank you very much. And the strategy, of course, will span the period from the winter of this year through to the autumn of next year. So it'll take us through to October, November of next year. And the review that you referred to is due to be completed by the 20th of September in time for then the draft strategy to be presented to the October meeting of this board.
Yeah, thank you.
Thank you. Any comments or questions on any of that? We'll obviously at the October board have a chance to comment on the strategy that is being brought forward. Okay, thank you very much, Ahidi. We will note your report. We'll move on then to item 11, which is the death analysis. Unfortunately, this item is deferred until our next meeting. Some further work needs to be done on that. So item 12, public questions submitted in advance. There has been a question. It's summarised in the paper that's been circulated. Given the everyday risks of city living, how is BCC convincing people that COVID is a real danger? The response is set out in paragraphs 3.23. Is there anything you want to add to that, Justin?
No, I think we've given quite a comprehensive response, and of course it's supplemented by the information on engagement that is covered in the overview item under item 6. Okay,
if we can note that question and response then, and item 13, test and trace budget overview, Justin.
Yeah, so I'll be brief on this item, simply say we're within budget. As the board is aware, we profiled our budget based on what we had given to us in the ring fence grant to take us through to the end of September 2022 to ensure that we have an adequate health protection response to respond to COVID and potentially other infectious disease threats with the Commonwealth Games and any other mass international events that we host in the city between now and then. Although the Commonwealth Games is perhaps the largest we also have several other international sporting tournaments and arts events over the spring and early summer before the Games, which will be really helpful because it will allow us to test and to feed back to the board how we are adapting our COVID response to ensure resilience for those events. Although it is not in the this paper, I should just make the board aware that of the 2.5 million of contingency we set aside in this year and the 3.5 for wave 3 response, we have actually drawn down at least 2 million of that overall 6 million already. It hasn't yet moved on to the ledger, which is why it's not in the report. But I wanted colleagues to be aware, because otherwise it does look like we're holding a very large contingency. And actually we have now been able to move stuff around and be clear about which budget lines things are coming from. So my hope is that next year you will see some of that wave 3 has been spent actually during the response to the most recent wave in this financial year. I'm not sure I articulated that quite clearly enough. What I'm saying is the spend from the 1st of April through to now in the additional response that we've done to the most recent wave of COVID is being drawn out of that wave 3 reserve of 3.5, and there's about 2 million to come out of it.
Okay. Okay, any questions or comments on the budget? No? Okay, again, we'll note that. Which takes us to other urgent business. Does anybody have anything they wish to raise? No. Date and time of the next meeting then, if we could know. Thursday, the 6th of October, and it will again be over the Teams platform, which takes me then to contains exempt information of the category indicated. The public now be excluded from the meeting. All of the politicians in Birmingham local authority, and indeed the 10 Birmingham MPs. We had a meeting with the 10 Birmingham MPs a little earlier on today, keeping us all informed and abreast of developments within the NHS as they have dealt with this crisis over the last 18 months. And as Paul said a little earlier, the NHS has been under immense pressure over that period. And I'm sure, Paul, you too have come under pressure over that period as well. So we all wish you well as you head off to your retirement.
Thank you. It's very kind of you both. Thank you.
Okay, if we could end the live stream, please.